This will be the fourth discussion about upper GI bleeding, and the four discussions were in fact based on the different ways upper GI bleeding can manifest. The first one we discussed hematemesis, second one presentation as melena, then the third one we discussed as a occult blood loss. Now, in a way, now this the way they present is related to a certain extent or to a great extent to the rate of bleeding. To a bit of a when it's bit moderate and maybe some severe bleed, they can manifest as a hematemesis. But if the bleeding is not very uh, high or and especially a duodenal bleed, they may totally present as a melena. And if the bleeding is very slow, then of course they will present as a occult blood loss. Now in a hematemesis, your differential diagnosis evolves of the upper GI bleeding causes. But when it comes to melena, then not only upper GI but from beyond the ligamented traits, the small intestine and also the right colon is included. And for a person present with occult blood loss, then of course the upper GI, the small intestine, right colon, but even a left colonic bleeder, if it's not very severe, sometimes they may present as with features of anemia, or sometimes the patient may have neglected bit of bleeding, but of course then he gets worried when he's short of breath, he comes. So the fourth one is when the bleeding is very severe. When the upper GI bleeding is very severe, sometimes they can present as acute severe bleeding per rectum. These are not a very common thing for upper GI bleed to present, but of course when a person comes with the acute severe bleeding PR, upper GI bleeding also has to be considered. So what is acute severe bleeding PR? Now when we say bleeding PR, it means that the person goes for defecation and with the stools there's some bleeding. But the acute severe bleeding PR is one thing is the onset is very acute. Now, with a person coming with bleeding PR, there is a bit of a history of weeks or maybe a month. Some people who neglect maybe more than that. But acute severe bleeding PR, one thing is a very acute sudden onset and it is very severe. And actually, what they come and complain is they just bleed with the stool. Now, there's no stool as such, but of course, they just keep on bleeding per rectum. So, acute severe bleeding PR. So, what is the differential diagnosis? So, it could be a severe upper GI bleed or a severe lower GI bleed. So, the lower GI, that means a severe small intestine bleeding or from a severe bleeding from the colon. So all these are possible when it's acute severe bleeding PR. So your approach will be, of course, first you do your ARB breathing circulation assessment and resuscitation. Very likely they will need oxygen by mask and very active form of hemodynamic stabilization, initially with crystalloids, but of course a significant number may need blood transfusions also. And then while resuscitating, it's very important to look from where it is bleeding, because it will be very important in this type of one to rapidly control, because it's a very severe form. So what are the causes for acute severe bleeding PR? If this is our differential diagnosis, so you can pause the video and list, because when you know the list, the differential diagnosis only, that with a quick history and examination, okay, you may be able to tell, okay, this is probably likely cause, but definitely you have to confirm it by some form of investigation. So pause the video and write the list of the causes of acute severe bleeding PR, keeping in mind that both upper GI and lower GI causes has to be listed. So it's very straightforward. But as a trial of your knowledge and application of knowledge, do it before you look at this list. So I'm sure you have listed all the causes we learned for upper GI bleeding, and for small intestine what we learned. Of course, generally Crohn's, there's a problem with the spelling there. So Crohn's generally doesn't bleed very severely though, and colonic malignancies, sometimes they can come with severe bleeding. Ulcerative colitis, it's a known complication that can have severe bleeding. Diverticulosis may be the cause. Then another one is angiodysplasia. These are actually they're not macroscopic. They're a bit of vascular malformations which can bleed profusely sometimes and present with acute severe bleeding. Hemorrhoids can bleed very severely, and of course, any of these, if they're on anticoagulants or subject to chemotherapy, any of these may start bleeding profusely or without even a background pathology. Sometimes anticoagulants or chemotherapy may induce severe forms of bleeding. So, if you take a quick history and examination, you may be able to identify just to rush. So, again, before listening to my talk, you can pause the video and take one by one, and you just think in the history, quick questions and examination, what I'm going to look for. So, esophageal varices. Of course, one thing is maybe a diagnosed one, and of course, you will have features of chronic liver disease, maybe alcoholic, and uh, on an examination, you will see the chronic liver fail features like the parotid swellings, gynecomastia, caput medusae, ascites, many things. Peptic ulcer disease, dyspeptic history, use of NSAIDs. I'm just giving the highlights only. Loss of appetite, weight, and epigastric pain. And these will have a history of bit of subacute. Sometimes the tumors, they may have a history proceeding with subacute obstruction, bit of colics, distension, loss of appetite, weight, and right colonic cancer again. They may have preceding history of iron deficiency anemia because they may be slowly bled for some time. So shortness of breath, exertion, and also they also may start obstructing the ileocecal valve, so they may have some features of distension, colics in the past if they are spread to the liver, right hypochondrial fullness. So again, these, like if it comes to left colon, they may give a history that they had a bleeding PR for some time which they were neglecting, or getting constipated for left colon tumor, especially the sigmoid. And ulcerative colitis, again a history of ulcerative colitis, either maybe patient is already diagnosed on treatment, or a history of ulcerative colitis like increased frequency of stools with blood and mucus would have been there. Diverticulosis, commonly diverticular happen in the left side, the sigmoid. So they will have diverticular pain for some time, some left iliac fossa or maybe central abdominal dull pains, and maybe they had couple of attacks of bleeding. And also if some cases of diverticulitis, they can go into stricture and they may complain of constipation. Angiodysplasia, again if they have bled slowly in the past, they may have features of iron deficiency in the history. Now they have started. And the hemorrhoids, straightforward, of course they will say the lumps of prolapsing bleeding, now it is very severe, and in the history it's very important to ask whether they are on anticoagulants, antiplatelets, and also recent history of chemotherapy. So quick history, and of course the general other inquiry of the other systems, medical history, drugs, past surgery, everything is important. So examination, most of the things we have discussed in the abdominal examination. Important things to look for maybe if there's any epigastric masses, enlarged liver, any other masses like iliac for left iliac fossa mass, right iliac fossa mass. Important to do a rectal examination. So with all this, sometimes you may be able to say very likely this is the pathology, uh, but in a quite a number, it may be not possible to exactly say from where it is bleeding. So if it's an acute severe bleeding PR, and if you have not definitely localized, but even if you are localized definitely, some protocol is very important because you can't miss out something, because these people are very severely ill people, and the diagnosis has to be accurate to for definitive treatment and to save the life. So again, because now you know the differential diagnosis, pause the video, and if you are the doctor, just think, okay, now these are the investigation to order. Write it on a piece of paper, compare and see whether you are correct. So again, I'm sure you will agree that the initial investigations will be upper GI endoscopy and just rule out or confirm if you definitely see a bleeding peptic ulcer, no problem, and you treat accordingly as we have discussed earlier. If the endoscopy is negative, then look at the lower, the colon, the colonoscopy. Now, uh, here you remember that you don't have to do bowel preparation here. There's no time to do, and it's not necessary because the blood will, this blood, the severe bleeding will usually wash out all your feces out at the beginning. So you do, it's not necessary to prepare bowel here. Now, what is the difficulty in doing a colonoscopy? As I discussed earlier, also if the bleeding is severe, it's difficult to visualize because the blood will be coming and touching. But you do try your best to wash, suck, and proceed, because if you can identify the area, it's very important because now. Now, some cases you support their circulation and look for their coagulation, and some cases may settle spontaneously, like a diverticular bleed can settle, and some of the malignancies, ulcerative colitis, of course, some may go into some response, but the thing is, if it's not settling, one may have to embark on surgery. So if one is going to do surgery, as I discussed earlier, it's very important, even if you don't know the exact pathology, to know from where it is bleeding. Say we have angiodysplasia in the right colon, and then the colonoscopy, the endoscopy will see that there is active bleeding in that area and some red patches. So we know that we have to go in and do a right hemicolectomy. Without localizing, it's very dangerous to go in, because the entire gut will be filled with blood, and you will not know from where it is bleeding unless it's a macroscopic lesion or you find something like a Meckel's diverticulum. So it's very important that you do this. Now, if the upper GI and colonoscopy both are done and you can't find a bleeder, then of course you have to look at the small intestine by some method. Do either a CT scan to locate what is the problem. Now, what are the, now this person is bleeding acutely, and sometimes CT may not be the best for the small intestine in that case, because again, if it's not a macroscopic thing, you may miss it. So uh, now, once the both these are done and you can't find the bleeder, or say supposing you have done only the upper GI but you can't do the colonoscopy because the bleeding is so severe that you just can't perform it. So in this type of situation, what are the other investigations that will allow to localize the area of bleeding? And we have discussed this in one of the discussions before. So you can recall that knowledge and write the two methods that you may use in this type of situation. One thing is upper GI and the colonoscopy is fail, and of course other ways to look at small intestine is there, but any method in case of bleeding that you can do. Also, if the colonoscopy is difficult, now even the colon you can't exclude. So what are the investigations you do? There are two tests. List them and start the video again or the discussion again. So one thing is selective mesenteric angiography. What we meant by selective mesenteric angiography is the radiologist, of the access is again like any angiographies from the femoral artery, uh, they selectively cannulate whatever the vessel necessary. Like you are doing a cardiac angiography, they cannulate the cardiac vessels and inject the contrast. Here both the all three vessels, they can be selectively cannulated in contrast injection and have a look. The celiac the is artery is possible, the upper supplying the upper part of the intestine up to the opening of the bile duct. Then superior mesenteric angiography is possible and inferior mesenteric angiography is possible. So with that, you can actually, you will not see you will not diagnose it's a carcinoma or the pathology as such, but definitely you can see from where it is bleeding. So this is a mesenteric angiography of the superior mesenteric artery, and there's a small intestine bleeding here. So once you localize the area, again, if you are embarking on surgery, you know this is the part you have to go and resect, or you may see like it may be inside of Mickles or wherever you can localize it. And then now angiography can be performed with severe bleeding. Actually, the sensitivity is more if the rate of bleeding is high, because the leak is high. In contrast, if the bleeding is minimal, then of course there won't be any point doing a mesenteric angiography, because so once the bleeding is settled that you want to find the bleeder, then of course angiography is not the best choice in that case. In that type of situation, isotope scan is better. Isotope scan can even pick up at lower rates of bleeding. Now it's important now to know that even now isotope scan, it will also stain all your vascular organs like the liver, the kidney. But of course, how to identify a leak? The specialists who do the isotope scans, they are competent to read and say, okay, it's bleeding in the ileocecal region. So they will localize the area for you. That will tell the region. So these are the methods that are available. To summarize, upper G endoscopy, either confirm, exclude, and if it is excluded, do the colonoscopy, and if you find the thing, perfect, fine. And but if both are negative, you have to look at the small intestine, and in that situation, in acute bleeder, of course, it would be better to do a mesenteric angiography, or the alternative is the isotope scan. And also, I said if the colonoscopy is difficult due to severe bleeding, again, these options are available. And then, what is the advantage? What are the advantages of angiography? One thing is, as I said, even in a severe bleed, you can do it, and I'm sure you know the other advantage of angiography. So pause the video, write the answer. Okay, now you can restart and see the other advantage of angiography is that it's therapeutic. Uh, there's a therapeutic usage where you can embolize. You can embolize and you can stop the bleeder. So it may be the definitive treatment for something like a angiodysplasia bleeding. And in all other cases also, you can get the bleeder, acute bleeder settled. But if you have something like a malignancy underlying, you may have to then of course do the definitive treatment. uh, but anyway, this advantage is available with angiography. So to summarize, now we have discussed upper GI bleeding, the four ways they can present: hematemesis, melena, occult blood loss presenting as anemia, and the acute severe bleeding PR. In case of melena and the occult blood loss, other than the upper GI bleeding, into a differential diagnosis, small intestine and right colon also comes. In acute severe bleeding PR, the entire GI can be the cause. So you have to look at all possibilities, and then investigations. If the hematemesis is only upper GI endoscopy, but if it's a melena, then of course it's necessary to do the upper GI followed by colonoscopy. If they are not showing anything, then you have to look at the small intestine by some other method, and those we discuss: CET, enteroscopy, small bowel enema. But in a case of bleeding, angiography and isotope scans are useful. If it's acute severe bleeding PR, again you first do the endoscopy. If nothing is shown, do the colonoscopy. Nothing is seen, then for the small intestine, best would be angiography or the isotope scan. And even for the colon, if colonoscopy is not possible due to severe bleed, these two options are available. And once you identify the cause for the bleeder, then of course the treatment is very straightforward. So which we have actually discussed most of the things earlier. So this we have discussed what to do. If it's a bleeding Meckel's, of course, if you are lucky with the radiologist to embolize and stop it temporarily, that's fine. But of course, you can surgically resect a Meckel's, and all this will need surgery. Ulcerative colitis. Now, most of the time they will respond to your conservative management, resuscitation, correct their clotting, and all that. But of course, if ulcerative colitis just bleeding, you can't stop. You're diagnosed with certainty, then of course only way to save life is to do a colectomy. And ulcerative colitis, it will need to remove the entire colon. uh, But in acute situation, you may do like a subtotal, just leave behind the rectal stump, because you can't spend a lot of time in these sick patients. But anyway, diverticulosis, angiodysplasia, if you can, diverticulosis significant number may settle with your constituent, but you have to be very observant, closely monitor. And of course, embolization is possible in these cases. If not, of course, if they're severely bleeding, then the resection of the involved segment is possible. Hemorrhoids, you can inject or ban them for the acute phase, but if they're just bleeding, you may be able to even do the surgery, but you have to be absolutely sure that it is the hemorrhoids and that you are perfectly excluded any other cause. And these will, one will have to actually correct the clotting profile for these cases, so the anticoagulant and the, if they're bleeding as a complication of chemotherapy. So you'll have to replace whatever factors which are deficient, and then get the bleeding settled. So that is again a look back of uh, the treatment options available for different causes of bleeding from the intestinal tract.